Dr. Ojemann is a graduate of Princeton University. In fact, there's a whole subset of neurosurgeons from Princeton University. And Laws, Rusty Rhodes, and they have their own little mafia. But he went to Princeton. He was at Washington Medical School, did his neurosurgery training again, his last AC there. Did his fellowship in pediatrics and epilepsy there. And you have to realize that Dr. Ojemann comes with a huge genetic burden. His family, the Ojemanns, are like the Kennedys or the Bushes of neurosurgery. His father is a legendary epilepsy surgeon in Seattle at the University of Washington. His brother is a neurosurgeon, functional neurosurgeon in Denver. And his uncle was Bob Ojemann, who was the legendary neurosurgeon at Harvard. Actually was our leading professor 20 years ago, and his photographs in our conference room. So he really comes to a rich heritage. He's a very well-funded investigator. He's sort of the model of scientist, neurosurgeon, NIH funding, and he really has, the handful of people that are funded from the NIH in neurosurgery, and they're sort of the intellectual elite. So he's been part of that. He's been a good mentor at, mentoring these people. He's also the Rich Ellenbogen Chair of Pediatric Neurosurgery. So he's sort of the quintessential triple threat. He's a great teacher, great surgeon, and great scientist. He has a really busy schedule, but he took time to be here with us. I'm very grateful. But I think the real reason he came is one of his trainees, Dr. Hai Sun, is with us, and we're very fortunate. He's very well trained. Hai, would you like to say a few words about it? Yeah.
Dr. Ojemann, thank you for visiting us. And when I was your fellow, I learned a lot from you, especially how to be persistent in pursuing research ideas. Now I'm still doing it, and so far no success, but I look up to you.
All right, without much further ado, Dr. Ojemann.
Thank you. That was very kind. And yeah, when Hai invited me, of course, I was going to say yes. So many reasons to be here, and really enjoyed already the time with the residents. And what you've done here is legendary, but to see it firsthand is wonderful. So thank you. What I want to do is share, and it's maybe a little untraditional for some of the talks that we give as neurosurgeons, but it's a lot of the work that we've done has spun out of our treatment of patients with epilepsy. So I want to do two things up front. One is, as our former president said, I didn't build it, and these acknowledgement slides usually go at the end, but I think it's important at the beginning just to see how many people are behind everything we do. Lots within the neurosurgery field. Dr. Sun, who was with us, I think actually somehow I deleted your name on the list. I was going to put it in bigger print, but it got, and he was there more years ago than we'll talk about already. But it's really been an honor to work with all these groups and many different funding agencies that come behind this. But then also to recognize that we're here for the treatment of patients. And epilepsy surgery is fortunate in that there actually is data to support our doing it, and that we don't take that for granted in neurosurgery. So the Canadians were able to do a randomized trial now over 15 years ago, where half the patients waited the typical year and the other half jumped the queue to get surgery. And the ones that got surgery did better than those randomized to waiting. And we may treat temporal lobe seizures, for instance, with surgical resection, which are done fairly similarly throughout the country. There may be variations in exactly how you do it. But sometimes when you find a place where the seizures are coming from, you need to do more detailed work. And you might be able to lead someone to a more minimal surgery, like the laser ablation. In this case, we can treat just the hippocampus through the ability to see temperature changes in the MRI scanner. And sometimes to get to that point, we need to record. And in the cases where we're surveying a larger area, we may have these invasive monitoring arrays like this. And one of the things that I often reflect on is this is not much different than how it was done in previous generations, the large craniotomies, putting these electrodes in and getting this data that we've been talking about. And sometimes we're doing it this way. Sometimes when we have more select targets, we'll be able to use these more selective or precise approaches. The advantage, of course, is you don't have a large craniotomy. The disadvantage is you're only seeing from much smaller targeted areas and can't comment about what's right next door. And I don't think we had this quite in place when you were there, but we've had the robot for a few years. And really, we're very agnostic about what's the right thing. There is no one path to getting the right information. But throughout any of these invasive recordings, you get a picture of the brain activity that's very different from what you can get from the scalp. And the majority of that difference is probably just simply distance, that you're talking about pretty weak signals, and if you're only a few millimeters from the surface of the brain, what you see is very different from going through the scalp and the skull. Especially in adults, the skull is pretty thick. There may be filtering properties of this tissue, but really it's the distance that makes a big difference. So when you're at the surface of the brain, you're not recording from neurons like many of the basic scientists will. In fact, you're recording from a pretty large population. So when we started this, it was a little bit unclear how much localized information you could get. We certainly know clinically that you can get beautiful data. So these are recordings on the left from an intraoperative corticography, and from the right what a temporal lobe seizure looks like that's coming from the mesial structures. And you can see these very high frequency changes where the asterisks are that precedes the evolution of the seizure. And you won't see anything on the scalp until you have a large amount of synchronous activity several seconds in. So that richness of recordings also shows up in the normal function. And I'm going to quickly jump into jargon, so I'll try to remind multiple times what I'm talking about. But these all have different names, these bands, and they really are in the order that they were kind of described over the past century rather than any other meaning. But you'll see frequency bands that are roughly, in some cases, very well defined, like an alpha wave. Those are usually what you see visually when you're looking at an EEG. But there's also these very fast activities that are usually called gamma. And when I talk about gamma, we're going to be talking about some very fast frequencies that are in the 70 hertz or above. So these, and in most natural systems, the fast frequencies have a lower power than the slow. It's hard to have a stable system that doesn't behave that way. And so these fast frequencies, you don't see them from the scalp. They're very weak. But you can actually see them from the EEG. And so when you break down any kind of a recording into these different frequencies, most of you know this, but the very slow frequencies, so we'll represent that in a power spectral plot. And we'll do a lot of that. And so you a plot that shows how much power is contributed by a given frequency in the signal. So when you have these waves that are going up and down, those are, or think of an ocean wave, the big movement is all at these slower frequencies. And then if there's a little ripple on top of the wave, that's a higher frequency. That will have a smaller amount of power in terms of contributing to the overall shape, but may have a lot of information. And so in fact, when you look at these different frequency components, there is different information in there. And one of the things that's known for a long time from scalp EEG is that over motor areas, there's a very strong dominant frequency. And it looks a little different on the scalp than on the surface of the brain and gets different Greek names. So, but the mu frequency is mu for motor. And we know that that's actually higher at rest over motor areas. And when you do something, a motor activity, that suppresses. And so you can see scalp recordings on the right, and that's been known and studied a great deal. And you can see that you can predict the side of, or see a difference between, say, left-hand movement and right-hand movement. And the contralateral motor areas will have less power during a task. And so the Hopkins group, led by Nate Krohn, looked at this in the corticography, and they wanted to both replicate that, but also ask, well, what's going on at the other end of this frequency spectrum? The energy's going down in this. Is it going up somewhere else? And they started to look at these higher frequencies. And now we take some of this for granted, but when you think about it, in order to look at something that's at 80 hertz, for instance, you have to sample at about 4 times that to get good signal. So sampling at something at, say, 500 hertz or a kilohertz over 64 channels, you know, for everybody from like the 5th row back, in your lifetime, that's no big deal. For the rest of us, that's a lot of data. And really the computational ability to do that didn't appear until maybe 15, 20 years ago. And so as we did that, people weren't able to look at very high frequencies and collect that data in the clinical setting. And so the story was still this, that at the low frequencies, these kind of 8 to 12 hertz, when you're at rest, that's the blue tracing, you have more power, and then when you're active, you have less. But then as you got rid of that limitation and looked at the much higher frequencies, what we and others saw is that there was not necessarily one given frequency, but this higher frequency domain was actually going up in power. And this is a log plot, so that's every tick there is tenfold difference. So if you go up to, and the slope is roughly 1/4. So if you go from say a 20 hertz recording up to 80 hertz, you lose 16-fold of the power. So these are very weak signals. But if you can measure them, then you can start to see changes that are very strong. And not only that, they're very focal. So another thing about the beta changes is they're not spatially very specific. So when you're active, moving your hand, the signal both at the scalp and from the surface of the brain goes down over a very large area. doesn't necessarily tell you something specific about the function of that piece of the brain. But with the high frequency, you really saw a difference, certainly between, say, hand movement and mouth movement. And so we could actually map out and recapitulate what we already knew about the brain, which was that different parts of the brain would map to different functional areas. So hand movement and tongue movement were different. You could map that out with this high frequency, and it was consistent across people. It was also had excellent signal to noise. So one of the first things we recognized is you could use this to generate a map of where these areas are. And if you didn't like the map, you could repeat it. So this is just some frames, and I'll show you a video in a second. But this is done in just a few seconds and based on only a 10-second baseline. So you can imagine the power of being able to create a map this quickly. I'll just give you just kind of a cute demonstration of how this might work in real time. Again, this is, in this case, a 15-second baseline, and you can see that we're just generating that map and gives us a clue about where motor cortex might be. And so we started to validate this and saw that, in fact, we got very similar results if we looked at stimulation mapping versus using this passive method. And it became kind of a way of doing a bedside functional tool. It became very useful in kids where you might not have a lot of cooperation over a long period of time. And we started to look at other functions. So, for instance, in language cortex, you can see this is a single tracing on the bottom, so very, very strong signal to noise if you take this average over these high-frequency domains. And so here's just putting all of the ways we know about localization together. This was somebody with a dominant left-sided grid electrode up here. That's the brain that Broca studied to define Broca's area. And then we see the tracing when they're doing a speech task. And then over that electrode, the high-frequency changes, preceded by just a few hundred milliseconds, the speech output. And then interestingly, when we looked in an auditory area, and usually seeing changes related to your own speech is quite difficult. You don't see a lot of activity. But in this one electrode, we actually did see weaker but present activity that just followed the speech onset. So you have what, at least if you're over an area of interest, can be a very powerful tool. We also wanted to have better behavioral definitions, so we started to take these patients at the bedside and move from kind of just simply acute moving the hand, but to actively record the signals where they were coming from. And when Dr. Sun was with us, he looked at a series of cases where we had this movement and said, okay, we now have this really amazing spatiotemporal resolution. Can we start to understand how areas interact? And so he looked at tracings during various hand movements, and knowing the exact onset of the movement allowed us to make these kind of comparisons. And what he found was a little bit unexpected, at least to me, which was that as you're doing these movements, you see signal not just in motor cortex, but also in sensory cortex. And maybe that's expected because you're moving and there's position and vibrotactic feedback. But the sensory signal actually preceded the motor signal. And then when you looked at where premotor went, it wasn't premotor to motor to sensory, but you could actually see that things went premotor to sensory to motor. And this started to get us into the literature of what they call the efference copy, where as you make a movement, you actually make a prediction of where that movement should be, and you're constantly comparing where the movement is to that map. And we could actually get at what those mechanisms might be by using these methods. But I'm a pediatric neurosurgeon, and so I also wonder, well, can any kind of a new mapping be useful? We often struggle knowing where functions are. You can do functional MRI in kids, but barely down to age 5, and most of the time you really can't, and they wind up being pretty noisy. You can get some information when folks are sedated by passively moving their hand, but you can also map it out using this method if these signals exist in kids. And so here's an example. Someone who had a previous temporal lobectomy. We're going to extend it up into the parietal lobe, but want to know where sensory motor cortex is as our guide limitation, as our limit. And we in fact can do this motor mapping, in this case just doing hand movement and seeing where the activity is. And we found that this was, when we compared it to other methods, was consistent and also very much easier for the kids to do. So we said, okay, well, what kind of signals might you find here? And so this is just an example of a 3-year-old who did 3 different types of grips. And then we just looked at the 6 relevant electrodes. And the orange blob are the high activity, high frequency changes. It goes up after you start moving. You can see these little traces of blue at the bottom. That's the suppression. And in general, it looks kind of similar to adults. It looks roughly similar across the 3 tasks. But there's a little bit of difference, and you might be able to exploit that to understand and predict what these different movements are. But the story may not be that simple, because we do know from scalp recordings that some of that beta increase really doesn't kick in until later. You often don't see much under about age 5. This is all scalp data in healthy populations. So we wanted to see what's really in our data, and so we looked at a variety of patients who had sensory motor coverage and did these different tasks, and we saw that this is what you're supposed to see there is not a whole lot. So you see a little bit of green in those things, and that suggests suppression for when they do the movement, but it's not spatially particularly specific. So this is in that beta frequency, the low frequency changes that should go down. And here's an 18-year-old doing the same task, and you see that it's really over the sensory motor cortex. Looks like the earlier pictures I showed you, where it was blue, and it's more robust. And in fact, if you look across the age span, you can start to see how this evolves, not just in terms of the strength, how negative does the signal get, but also the peak signal starts to migrate into faster frequencies. So you see something's going on with these networks over time. And here's another example of a language task. So turns out you see similar patterns there, where the orange, again, is 0 is the onset of the speech task. Blue is the younger kid, orange is the older kid. You see the orange is the dark colors, the brick red and orange. That's the increase in higher frequency activity. That's there early on, actually pretty robust when you're young. But you don't really see these big blue swaths at the lower frequencies until you get older. So these two networks are at least in development, behaving quite differently. And here's just an example also of areas where the activity goes negative. We'll talk about that in a little bit as well. That starts very early in life at age 3, but these lower frequency changes that you see here, the decreases don't show up until later. So where are we now? And we know that we can map out these different functions. It's a strong signal to noise. It's early. They're pretty early in life, maybe even earlier than age 3, whereas the lower frequency changes are age dependent. So we start to get more and more interested. What can we do with these high frequency signals? They're really consistent across people. They're robust, and you can help them as a brain mapping tool. Well, one direction we went is into more basic neuroscience. So it's known that there's parts of the brain, I showed you briefly, will actually decrease when you do a task. And I remember I was a resident and did my year of research with Mark Rakel, who was one of the pioneers in this imaging. And I had this really kind of clunky old system, and you had to write a bunch of instructions to make the images display. And I had flipped a signal. And most of the time when you're looking at cognitive changes, they're about 5-10% difference. So you scale the picture to enhance that. We were just showing what areas of the brain were active for language or memory. And I had flipped the positive and negative, and I got a picture that looked a lot like this, except it was 40%, so huge signals. And so obviously I'd done something wrong, but what I'd shown is what the negatives were instead of the positives. It turns out when you do a cognitive task, you get these incredibly strong decreases. So another way of saying it is when you're there at rest, you have these really strong increases in some of these parts of the brain, basically the frontal lobe and the parietal lobe. And I wasn't the first to observe that, but it was kind of fun to stumble across it in that way. And we know these areas are actually active when you're doing some of these introspective things, like thinking about the future, thinking about where you'd rather be right now, what are you going to do in a difficult situation. These areas ramp up. And we were able to show, when we looked at them, that actually you get a very robust timing-dependent change in these areas. So these were language tasks, and we just looked at different trials. And in each and every trial, you got this big drop-off in the signal in these orbitofrontal areas. And it matched what was known about these. And the other interesting thing about these areas is you can actually see them in your resting data because they are very strongly correlated. So Hai and Dr. Ledbetter were showing me some of their work that's a little more prettier pictures than what I have, but where you can see these changes in these areas that they actually oscillate together. And so we looked at that in corticography signals and said, can we see these same kind of interactions? And not only could we, but we can actually start to make comments about the timing of it. And what you see is that their fluctuations occur at a very distinct time scale that's really slow. It's about 70 seconds. And it's fairly specific to that area. Now, that's probably about the last I'm going to say of that today because nobody knows why 70 seconds, what's the biology behind that. But we can start to learn that information. And we can use that information clinically because pathology seems to disrupt these networks. So here's an example of a tumor in the middle of one of these networks that should have lateral activity on both sides, and it's out because of the lesion and the surrounding seizures. These are some kids that I was talking about yesterday with both of you that have unilateral disease, and you see that there's these networks that should be bilateral are very disrupted and don't have normal distributions. But really our focus, a little bit of a tangent, but our focus has been more around
the cortical representation of motor cortex, and that's what I'm going to talk about for the rest of today. And the brain is it's really cool how it's obviously not a one-to-one to your body mass. There's definitely areas that have a larger representation. This is obvious to all of us. When you have a stroke, there's a part that doesn't recover is dexterity of the hand as opposed to proximal function. When you map out, either with functional mapping or stimulation mapping, you get a lot of hand and mouth representation. It's true of every mammalian brain that it has this sort of behavior. When they study whisker barrels in the mouse, it's because each whisker has a giant representation. And this is taken to kind of a grotesque extreme if you're a mole, or otherwise use your teeth or other things. And that star-nosed mole is just gross, so I like to put that up. So several questions about what's going on. Is this the whole story? And what does this mean for the kind of studies I've been talking about? And so one of the things we asked is when you have these 1 centimeter resolution arrays, what's the best you can do in terms of behavioral representation? What's the resolution of different types of behaviors? And what we noticed early on is really at the digit level, it's quite good. So moving your thumb and moving your index finger activate spatial areas that are relatively easy to detect. So we can almost always separate out thumb and index finger movement using just these arrays. And that really pushed a lot of the collaborations that I've been fortunate to be involved with over the past 10 years, and many of those people, 15 years now, and many of those people that I showed in the first slide are involved and funded by this. And so this is a National Science Foundation Center that is run through our Department of Computer Science. And this is really its goal, is schematically, is to use corticography as a base of brain signal and use that for some kind of a useful effector. So this gets into this whole realm of brain-machine, brain-computer interface, basically meaning get the brain signal to the external world in a manageable way or engineerable way, and then also get the information back. And this could be useful for a wide variety of neurologic disorders. There's many ways that you can interface with this model, whether it's in your detection technology, or in my role obviously being in the brain signals and understanding what they might do. So on a very simple level, we started by saying, well, what is it that, if we want to reconstruct, so let's say grip, what's the way to do that? Is it adding up all the digits? Is it, how is the motor cortex working for that? And it turns out if you look at just behavioral data, you can break down every grip that you do of an ordinary object. Almost all is explained by these two axes. And these aren't very natural, so it's a little hard to see what's exactly going on. But basically there's an open and closing dimension, and then there's kind of what's a claw pinch dimension. And depending on how much weight you do of each of those grips, you can reconstruct the grip of many, many objects. So this is just those two axes. And in fact, as long as you stay on that V that you can sort of imagine is there, then everything from a CD to a rope to an ice cube will fit in some combination of those two domains. So what if you could get two signals that were independent and drive that? So here's just an example of that. And so we tried to do that. So we had a patient who had the electrodes in, and these aren't actual electrodes, they're a combination of electrodes put into two independent signals. And then we said, okay, here's what we want it to look like. We want this hand to look like a jar, and this is a virtual hand that's driven purely by brain signal. This is kind of the calculated space between these two. And so you give them control, and they can kind of get the hand into a jar shape. And, it looks reasonably like a jar. And now, go to the next one. Now, you want to look at in the case handle. So we give them control here in just a second. Just showing that there's, okay, here we go. So they make their move, and they can get it into a case position. There you go. And that's obviously different from the previous example, a different shape. And then finally, can they get it into a piece of paper? And we give them a little, help them kind of in the general direction. You can see they do have some free movement, and now they're going to move it into how you would pinch a piece of paper. So, we thought that was pretty good. Not great, certainly nowhere near what you would normally do, but this is his MRI. And so that level of dexterity, this guy actually had a neonatal infarct. He'd never had it in that limb, controlled from the signals in that area. So not only did, in this case, even with relatively poor dexterity, he still had residual signals, but he very quickly learned the ability to use that in a way that if this wasn't a virtual hand, but actually an exoskeleton or some other implantable device, could imagine very quickly would restore function. So we thought that was, I thought that was quite remarkable. So the general setup we do to study then is a little less dramatic, but we have the patient there, we split the signal. That's Kai Miller, who's now at neurosurgery faculty, so this is a pretty old signal picture. But we take usually one electrode as our signal over motor cortex. That really helps with because we only have a day or so to do these, so it has to be an intuitively obvious task. So we can say, okay, move your hand or move your tongue, and this will give us a signal. And so we use what I showed you, that the rest condition and the active condition are different. We pick a band that's going to, the signal drops off very quickly, so the lower we can go, the better, and we don't want to get into the 60 hertz noise. So we have good signal in this band of frequency, and then that power is the velocity of the cursor on a screen. So a pretty simple task. You move the cursor up when the power's high, and it goes down if the power's low. And the first thing we did is try to convert that to tell the patient not to think about moving, but think about imagining moving. And they still were able to do this pretty well. They had a drop off in their power, but statistically it was still good. And then they started doing this task, and the first thing we noticed is their power started to crank back up again. Sometimes even stronger than it was originally. And so that kind of got us into this game and community that's out there. So upper left is one that was very popular. This was an individual with tetraplegia, and she had the brain gate device, which is 64 channels that penetrate into motor cortex, and she could get control of that arm. And the one that I think is a little bit more impressive actually is the Pittsburgh group that put a high-resolution corticography array over an individual with spinal cord injury. And he's able to move that arm, and you can see can tip a ball out, get it into a jar, do a lot of high precision. And meanwhile, we're playing Pong in the upper right. So you lost it there. So we thought, okay, that's good. We can learn some things about feedback and whatnot, but what can we do with this? And one of the things, though, that we noticed that the other groups haven't talked about a lot is that you actually get better and better at this. And so you see that each of these is a different patient. And these tasks, you start out where it's not that intuitive, and so your percentages or performance is pretty close to chance. And then usually within about 10, 20 minutes, you're doing a lot better. So what's going on there? This may be where I may have crashed it. So what's the brain is now going to go into two different states. Second, I have a problem here. I was telling people before I came in, I used to be embarrassed by this, but then I was in a engineering conference, and this group was struggling with their PowerPoint, which wouldn't by itself be a big deal, but there was representatives from Microsoft, Google, and Intel doing on it. So I was like, okay, if they can't figure it out, then there really is no hope for any of us. So let me this wasn't even a video, but no, I got it. I'm almost there. It's beyond hope. It's not worth Here we go. So what we're looking at, what I became interested in, was this question of the change in behavior. So as you got better at it, you're still doing the same task. We've absolutely guaranteed you're using the same part of the brain, because you have to use this cortex, this one electrode. But something's going on, and we can't tell you anything about the neuron, but we know the behavior. We're seeing it, measuring it, and we know at least something about the cortex where we're covering. So that's motor cortex and surrounding areas. And oh, come on. So what I hope to show you is another video. It's really doesn't like this. So what happens, I'm going to skip the video, but what happens is you start out where it's really hard to move the cursor up and down, and then you get really good at it. And that happens over the course of just a few minutes. And so what we were interested in is what happens to the brain during those two different states. And let's see. Yeah, here we go. From here. And so there we go. So let me see if it'll let me go back. Here we go. So we start out, and guys, on the bottom right, let me just take you through it since the video isn't going to work, but the bottom right is the brain activity as you start it. So their performance is terrible, chance is 50%. There's not a lot of activity. Here's the electrode that controls. And then they get more activity in this area. And then the actual amount of red and orange doesn't change a whole lot, but the accuracy goes up. So if you just say how much power is there when you're supposed to be moving the cursor up versus moving it down, if you're doing it correctly, you only have power when you're going up, no power when you're going down. So all the blue dots should be below the green line, all the red dots should be above. So when you start, it's all over the place. You don't know what you're doing. Then you start to really crank the power in the up. So you say, okay, this is what I need to do. And you just go all out. But you don't pay much attention to the other part. And then you take your foot off the pedal, off the gas, and the power isn't going up so much, but your accuracy goes way up. And that's actually, turns out that's how you learn most things, is you just kind of go all in, and then you refine. And so when we thought, oh, this is really cool, and then we did it the wrong order. Of course, we went to the literature next, and it said, oh, yeah, of course, that's what we were going to find. Okay. Yeah, I'm going to cry uncle here. We're going to. There we go. No. Yeah, it freezes. First vanishes and then freezes. So let's try one more time here. There was a party in Switzerland that wanted to ban PowerPoint. That was their platform, because they argued it ruined creativity, and that was bad for society. So. Okay. So one of the things we were able to measure is what happens in these two states. I mean, just like movement or not movement, these are two different brain states. One is a learned state and the other not. And what you saw, so the part that's over mouth motor area there is getting stronger and stronger in each panel. And look at what's happening in the rest of the frontal lobe. It's actually getting less red, less strong. And so if you subtract the end from the beginning, you see some power increase here where the control electrode was. But look at all that blue and green. That's all less. So that's all areas that were active when you started. And then when you learned it, those areas decreased. And so you can actually see this on a trial-by-trial basis because the signal is so strong. So this was that panel F is this kind of premotor electrode. And you see that when you're trying to move it up, you've got a lot of power. 0 is when the task begins. And you have all this power. And then the horizontal black line is when your behavior changed and you shifted into a more learned state just by behavior alone. And you can see that activity is no longer there. So of course the activity in the cursor area is still going, but these frontal lobe areas are no longer engaged. And you can see that. Some behave for all conditions, up and down, others just for up. And we were able to put that all together and show that there was this network, this was across 8 patients, where both frontal and parietal cortex was more active when you started the task than when you ended. And these areas turn out to all be interacting with that motor cortex electrode over time. So for instance, there's these very strong temporal interactions. This is the first panel on the right is the weight of the interaction. It was very strong for ventral motor areas. They had the strongest, the first panel is just the number of electrodes. The second panel is the strength of the electrode. And then interestingly, for the strongest panel only, you could tell that it actually preceded the motor signal. So this area is active first, and then we can show that that precedes, and so we infer that that influences the activity in that motor cortex. And as you get better, that degree of interaction actually diminishes. And this has been seen before. So if you look at, this was just a functional MRI study of a learning task, very active when you start, less active when you've learned it. And then if you look at in this meta-analysis, it just looked at the focus of activation across a wide variety of verbal and nonverbal tasks. And you see that they're finding the exact same areas that we are, both frontal and parietal, that are active during this task. Another marker of learning is sleep and sleep spindles. So sleep spindles are something you can see in your EEG. They've been correlated with successful learning. So if you have a new task and you have a lot of spindles, you learn it. Nobody knows exactly the spatial specificity of that. These were 3 tasks, 3 patients, 2 from us and 1 from the Netherlands with collaborators, where we were actually able to collect sleep data before and after they learned their BCI. So if you think of the logistics of this, it wasn't easy because you have to have data that's good data and good sleep. They have to learn the task, and you have to get another day of good sleep. And then the techs have to not have erased the data before the time you get it, and so forth. And what we found is that if you looked at the change in sleep spindle density from before and after, and most electrodes actually went down, but if you look at the electrode that you used to learn the task, in this case it was number 25 at the top, the sleep spindle density actually went up. So you have something, and this was true, the specificity was true across everybody. The bottom one didn't learn, and he didn't have specificity. So there was something about the presence of these sleep spindles that we were tapping into as well. So lots of really interesting dynamics that were going on with this new task. And the other question that, and we saw, as I showed you, evidence that these dynamics are really focused towards motor cortex. So what's going on there? And if you go and look at the primate literature, motor cortex really actually isn't that static. We always draw it as a fixed map, but it isn't. And this, we won't get into details in the slide. The point is that where the red and the green are change over time, and it's with training and doing different things. So this is an animal, and so where you're recording from, the tuning of that area can change depending on the task and practice, and it can change pretty quickly. And there is a reorganization that you see with that training. And we can see it after injury. So this is after an amputation. This is based on data from TMS and functional MRI studies, and that the neighboring areas actually expand their representation into when you've lost the target limb or target organ. So this is an example of the same phenomenon. So is this static? And we're actually in a unique opportunity to look at that. So we started by saying, all right, we need some kind of fixed measure because we're doing a bunch of different tasks, and if you do it a lot, you might change. So here's something that was always the same. That was just, this is what engineers do, is they find some simple way to figure it out. So we got that bulb. You have a target force, so you always do the same task. We did that before and after this learning task. And what we did is said, okay, squeeze the bulb, then we'll find the part of the brain that was most tuned to that task, and do the brain-computer interface, and then repeat the squeeze task. So what we do is we'd squeeze the ball, you get this activity over hand sensory motor cortex. We would take that area of the brain and drive the brain-machine interface off of that. And then we'd repeat the squeeze. And what happened is the activity in motor cortex dropped. So you're doing the exact same thing, you're achieving the exact same goal, but you're no longer using that piece of brain in the same way. Now, maybe it's fatigue, maybe it's something else, but we had no evidence for that. And so it really was acting as if we were taking a part of the brain and repurposing it. So we changed the homunculus to look something like this. Now, there's two problems with that. One is the potential for fatigue. The other is this would imply that I did something and mutated the hand in some way. But their hand function was fine. They didn't complain of any problem. Their dexterity was grossly normal. So had we really done something weird to the hand? And so we designed a different task in conjunction with the group in Germany, where we now took the cursor starts in the center of the screen. Let's see if I can get, here we go. Starts in the center of the screen here, and then you're going to move it to any one of these targets. But the way you're going to move it, you'll move it up and down based on the power in that electrode, but you'll move it left or right based on pressing a key. So there we go. So it's going to be up and down, and we're going to use the same piece of the brain that you use for pressing the key to drive the cursor up or down. So you do a key press, hand motor cortex is active, we take the most active electrode and make that the imagery control. So it really should be difficult, right? You should have this complete confound between the two directions. So we make it hard on purpose. We take an electrode, again, we drive the cursor up or down, and then the key press should activate that same area. So if you do that, it should be no problem to make it go up, right? You just have, well, there's no problem to make it go down. You just rest, don't do anything. So the cursor won't move, it just goes straight down. To make it go straight left or straight right, you have to press the key but suppress, but not activate that piece of the brain. To make it go up to the right or up to the left, maybe that's not too hard because the imagery piece of it will go up and you're moving your finger one way or the other. It should be impossible to make it go bottom left or bottom right, because to go bottom left, that means you're suppressing that area and pressing the key. And we selected the electrode so that wouldn't be the case. So somehow, though, or I wouldn't be showing it, somehow within a few minutes you can do it. And so if you look at these, the most interesting ones are the green arrows. here, and compare it to the purple arrow ones. So again, red is high. The band is that famous band of about 75 to 90 hertz, and blue is suppression. And you see that even though you're moving your hand the exact same amount, the left is one key, the right is another key, you're able to take that piece of hand motor cortex and completely independently modulate it, depending on where you want the cursor to move. And you learn how to do that in just a few minutes. And so that means, and not only that, it's specific to that area. So for the top graph is if you move a centimeter or two away, you no longer see this effect. So it's just those electrodes. And really, very surprisingly to me, it's specific to that band. So if you move away into these higher frequencies, they aren't modulated. So somehow you're picking out the circuits only involved in what you're asking them to modulate. And so we're not replacing that part of the homunculus, but we're actually somehow adding to it. So somehow the areas we're recording from over motor is probably not exactly the same as M1 in the primates, but it's what any of us would call motor cortex. You have that freedom to modulate. So for motor systems, we have this very flexible mapping tool. We can use it as a neuroprosthetic signal. It's completely novel. No one can possibly have done it before, but they can learn it using the same native learning networks, and yet it alters this motor network. And then for the last few minutes here, I want to talk about some of the work we've done in the other direction, which is that you can also engineer these sensory systems. That's just a shunt because I'm a pediatric neurosurgeon, so that should be in there. So there's this other angle. How do you get information back to the brain if somebody has a significant impairment? And the way that you go back to Penfield or even Cushing used this cortical stimulation to try and evoke sensory responses. And so these are milliamp type currents. They're short frequency durations. There's not a lot of science as to why we do it this way, but it is the way it's been done for over 100 years. And what you're stimulating is probably not primary sensory, like area 3 or primary somatosensory, but you're stimulating from the top, and then it's the spread, and it's over a very large number of neurons. So there's something very, not necessarily very natural to it. So one question is, well, what can you do with that? Those kind of very unnatural stimulation. One thing that was we kind of put together a little paper on. One was obvious, and that's spatial discrimination. You stimulate more superior medial, you'll get hand, more lateral, you'll get mouth. And that, again, Penfield and Woolsey and others did this. Amplitude discrimination, still not clear how low you can get. It looks like at least 300 microamps. You can tell the difference between the intensity of stimulation. And then also frequency. So if you stimulate and turn the dial up to 100, that feels different than 75, for example. And so can you use it as effective feedback? I mean, it's this really bizarre, unnatural thing. There's a little bit of variability you can put in, but not a lot. So we wondered if you put it into an actual task, would that change how you perceive and how you use these signals? So the first thing we did was some more sophisticated psychophysics to try and figure out its level. And then the other was to make it a useful feedback. So in this task, what we did is you had the glove again. You have it's one grip dimension. So either this is continuous measurement, but it's the degree of grip. And then unknowns to the subject, we define what our target shape is. We actually vary that target over time. They don't know what that is, but they are given stimulation one level if they're right in the target, and if they go too tight from the window, they get a higher stimulation, and if they're outside the window, they get no stimulation. So those three states, and what you see is that they can do it. So they start out with the hand wide open, they close it, they get information that it's in the right window, and then as they go too tight, the stimulation gets too high, and they can bring it back, and you can see that they can stay within this oscillating window. Obviously, not everybody's going to do that well, especially up front, but look at the learning effect that you can see as they start out really struggling, and then after about a minute, figure it out and start to use this. So this relatively simple model, but it tells you that cortical stimulation could be useful, that there isn't any immediate habituation, that even though it's very odd feeling, you could use it as a feedback tool. The other reason this may be useful, actually, is a work I was able to do as a resident. We had a patient with a glioblastoma that they had done a wake mapping on who had coincidentally had a traumatic amputation 20 years prior. And when we stimulated where sensory cortex should have been for that, he still got a perception of that hand. So 20 years later. The other reason I like to show this is just as a member of the Southern Neurosurgical Society. I submitted this to the Southern as an abstract in 1994, and it was rejected. But then I got to give a talk there 2 years ago and presented this to the group. So yeah, so persistence and revenge. That's kind of the two. No, so what can you use stimulation to invoke different percepts? I mean, you have this idea that this is maybe a very, very solid system. So I was able to, the hospital and department were willing to let me go for a couple months in Europe, and there was a group in Stockholm, and Kelly Collins is just finishing up her residency. And we did, you see, I ate well but lost weight in Europe. It was good. But that's not my hand in front of us. That's our visual hand. And then Arvid there on the left is a Swedish graduate student. He's, we figured, almost 1 million times for his PhD. He would touch the person's own hand and this artificial hand simultaneously and do it over and over again. And you very quickly elicit this illusion called the rubber hand illusion where you think that hand is yours. And it really doesn't matter. It's a very robust illusion. You could have no actual artificial hand there and you still think your hand is there. They actually take that knife there and go after the hand. And I may or may not have shrieked, I'm not going to admit, but it's a really strong illusion. And one of the things we studied was what are the parts of the brain behind that. It involves a lot of these multimodal areas. And here you can see very strong parietal cortex activity that was active during the illusion. And the illusion is very dependent on the timing and space. You can't touch a different part of the hand. So if you touch your own thumb and the mannequin's wrist, you won't get the illusion. And if they're not temporally synchronized, it won't work. So we said, well, can you do that with cortical stimulation? Is this a strong enough signal that this is possible? So the model here is that you're touching the patient's hand, the mannequin, which he's looking at. His real hand isn't getting anything on it, but you're stimulating the brain by triggering it off of the signal that you touch. So you've got a device that closes the circuit when it hits the skin, and then that triggers the machine to give a standard clinical stimulation. So he'll get a sensory perception at the same time that the mannequin hand is touched. So we obviously have to identify what percept you get when that piece of the brain is stimulated, and then give the activation during that time. It has to be synchronous like that. There's my PowerPoint wizardry there. And if it's asynchronous, you shouldn't get the illusion. So if it comes at a different time. And sure enough, so the scale here is what they call an ownership rating, which is an established thing. And if it is synchronous, then they very quickly, within really only about 5 trials, get the illusion. And if you don't do it that way, if you have placebo stimulation or it's not synchronized, then they don't get it. So that was one subject. This person actually didn't have a very strong temporal dependency. So if it was off by the timing was off by a little bit, they still got the illusion. And one of the problems is that stimulation actually is slow. So if you do a reaction time measurement and touch the hand, how quickly they can respond if they felt a touch, stimulation is about 100 milliseconds or 200 milliseconds slower. So something's going on. You'd think, oh, we short-circuited all the peripheral nerve and thalamus and all that. But it turns out that whatever you're delivering is so abnormal that it needs another refiltering of some kind. And we're trying to get at what those mechanisms might be. And you also experience this proprioceptive drift. So it's really weird if you get the illusion and then they say, close your eyes and point to your hand. And you know that the mannequin was there and your real hand was there, but it's almost impossible to suppress that difference. You can't. No matter how hard you try, you don't compensate back to where your hand is. And we were able to get that same degree of drift with this approach. And then the other thing that's going to close up my talk is we've as part of this center, there was a neuroethics component. And the way we address that is we actually have embedded philosophers, which is kind of a fun concept. So they come to lab meetings, they observe experiments, and they interview the patients. And so they're looking at things like, is this really natural? And then they asked, and that's where I would have stopped, and they said, well, is that your hand? And do you have a sense of ownership of that? And they were able to establish that when you're doing the illusion, that people really felt like this was my hand. And so then they start to ask interesting questions, which I don't want to ask too much when we're in the middle of the experiment, but so if they own that hand, then can you stop the experiment? What does that mean, since you're taking away their hand? and we'll talk about that in a second here. So there's definitely dimensions of feedback that are available. It's unnatural and slow, but the context can increase its utility, and we can certainly drive a sense of a natural sensation and funded by different things. So then the next application that we're in the middle of is that we had this unique opportunity through Medtronic and the deep brain stimulators, where they opened for calls, and we were able to get a donation of 5 of their devices, where it's standard deep brain stimulation for central tremor. So same thing you do here, everyone does, where you put the target is in the thalamus. But instead of just being stimulating at an open loop, they designed it so that you can put a trigger in to stimulate based on that trigger. And so what we propose to do is to make that trigger a signal from the brain. And so all the motor signals I was showing you, are there any that could be used? So here's the basic design. You have the device. It goes into the thalamus, but then there's an extracortical strip that sits on the surface. And this is something my partner Andrew Coe worked on. And the first is, could you get good signals? And so he put the strip in, and he always got it over motor cortex. And you could see that those 12 and 24 hertz bumps, so it looked like motor cortex. So we thought, okay, well, that's pretty cool. What happens when you do something? But before we got there, the philosopher stepped in and said, well, this is pretty interesting because deep brain stimulation, it's in there forever and it's yours, and there's been a lot of work on how does that change people's self-perception. So is it, are they in some ways not really human? And there's an interesting mix here because one of the things is the interpersonal relationship problem. It's known that if you have successful epilepsy surgery, the divorce rate is very high after that. And so there's a lot of what is health and how much does that interact with relations. But the ones that are of particular philosophical concerns are some of these cases where the DBS changes somebody's perception or personality in a way that then, if you turn off the stimulation, makes you wonder what are you doing to that person. So cases where deep brain stimulation induces euphoria, cases where this on stimulation and the off are both mentally at least impaired, may be the wrong word, but different states, and the judgment is different in the two states. So which is the correct judgment? So with those in the background, we went ahead and for brief periods gave the person, well, first of all, we could see these beta, so this is now the low frequency decreases. And we could see it in the device, so these are recordings from the device itself. And then the bottom is the limb accelerometry that we can measure. So when the arm moved volitionally, so you moved his arm, you could see the signal drop out. And the timing was really good. So this is an engineer's version of what we're doing. So we have the brain signal, you have the sensing, you have the processing on the left, and then that goes back to the stimulator. This is the philosopher's version of what we're doing. So we're going to do open loop. Normally it's open loop. These will be closed loop. And the possible benefits here are, the argument to the FDA was battery conservation, which is true. We're going to have it on for maybe a third of the time as normally. But also now you could potentially volitionally use it and not use it depending on for whatever purpose you want it. And so this is a little busy, but this is what happened when we turned on this ability, and we've only been able to do that in about 2 people so far, just for brief periods. But the results are pretty interesting. So the red is when they're moving or not moving, the red bar in each one. The top is the magnitude of whatever they were trying to do. You can tell from these accelerometers, they can figure out what's tremor and what's normal movement. So they didn't have a lot of tremor when the red was on. Then there's this brief period in the middle where the device was off, and we're going to go into that in just a second. And then you see the beta movement in the second to the bottom one, and then the stimulation that was delivered. So if you zoom into this period where they had it off for a while, what you see is that near the end of it, the tremor started to come back. You could see that the beta, that's that orange at the very bottom of that spectrogram, was starting to get high. And then when they started their movement again, it went away. Stimulator went back on. This is the beginning of all the sections with the red bar on the right. So over here. So they're going along, the stimulator's on, and for whatever reason, their beta comes up, they're at rest, it goes off. Tremor starts to come back, they want to make a movement, which is this red. So they start to make their movement, the beta drops out, and then that makes the stimulator go on, and then that suppresses the tremor. So in that instant, what happened is it was the interest and the intent and the initiation of the movement that actually started the tremor and started the stimulator and suppressed the tremor. And it otherwise was off. And so and we don't know yet what people are going to do with that, but I think everything that I've shown you to date would suggest that your ability to manipulate and incorporate these signals into your routine is pretty strong. And so you'd predict that they would use that in a way that's adaptive. So this was the first patient. This is what the philosophers talked about when they interviewed him. So he was a veteran, had this tremor for 5 years. It really interfered with his daily life. Couldn't do his job. Drugs he didn't like or didn't work. And so in the open loop, he had this great control. Wasn't super happy about having this metal inside of him, but overall was happy with it. And so he, it's only a day's worth of trial we did with him. And we also gave him the ability to do that cursor control with that same signal. He didn't like it too much. He thought it was pretty difficult. He developed a lot of frustration. Couldn't relax and felt he was kind of speeding up himself. And didn't think that would be a super great tool to use. And again, that's not quite the same as this closed loop thing, but the idea that the early experience of it may be very important in terms of acceptance. So it's fine just for me to say you'll learn it, but if that doesn't come quickly, they may not. But there will be challenges with ultimately incorporating this into clinical use. And I think that success will depend on understanding what's practically the reasonable expectations, and then what the ultimate social needs will be. And so I think we get to talk more about that later, but that's what the philosophers are thinking about. So a summary of all that, and it's a bit of a whirlwind, but I think we saw that we can certainly have great information in these direct recordings, that the motor map will change and respond to new tasks. There's large parts of the brain that are already there to engage in learning, no matter how novel the task is. We can begin to give sensory feedback, and that somehow there'll be interaction with our native cortical networks. So it's exciting, and hopefully, I think the other message, really, especially for the residents, is everything that we got there clinically was there 30 years ago, the stimulation, the mapping, but it wasn't until technology kind of caught up with what we could do. So I think those kind of opportunities exist throughout our field, and it'll be the prepared mind that'll be able to take advantage of it. Thank you very much.
What was going on in posterior cortex when they were?
Anybody interested? Yeah, so when you're doing, so the reason this illusion works is the multisensory integration. So you have a visual event that tells you your hand should be being touched, so you can interpret the sensory that way. And so what you saw is that this was, during the maintenance of the illusion, that area was very active, and it's pretty far posterior. So it wasn't active when you actually got the sensory part. It was delayed about half a second. So somehow that information's rattling around and comes together there or something. We're trying to actually stimulate that area and see if we can keep the illusion from happening. Yeah. And it's one of the challenges with the primate correlation is a lot of those things that are recorded from are buried. And so I'm a little wrong here. We probably aren't recording from M1. It's probably more area 6. And so some of those are well less worked out in the primate what they're doing. Mm-hmm. I think so, yeah. Yes, so we're talking about the parietal areas, and in fact, Richard Anderson at Caltech has at least one subject that has one of these microarrays in that area. And the richness of environmental information in there, she can do all of these arm-reaching tasks with those cells.
My question is for the residents. How can you get more sleep spindles so they don't sleep as much and can learn more? I'm just kidding.
That's right.
Any other question? Hi.
So it seems to me when you during the learning process at the beginning, what you find is there's a bigger area of brain representation or activation. As you became more proficient, actually the area evolved to become more and more focal. Do you think this was driven by maybe efficiency, meaning less connection, fewer brain network that's utilized? Maybe that's an indication you become more proficient.
Right. Well, it has to be. I think the other thing is it speaks to how the motor cortex isn't mapping necessarily directly to a muscle or directly to one specific movement, but somehow a pattern is generated, and so just as this becomes a pattern that doesn't require a lot of computational energy, moving the cursor starts out as being computationally a complicated thing, and then you've done it so many times that whatever pattern you used to do it is now set. And so there isn't a bunch of calculations of why did this work, why didn't this work. So I don't know, and I don't think anyone knows whether this is more, does this happen? It probably doesn't happen at the synaptic level. It's awfully fast, maybe. But probably figuring out of the 1,000 different patterns or billion different patterns that are possible, given this array of neurons, which one do you pick to solve a task? And that there must be some way that gets, you come to some answer. And once you're happy with the answer, then you stop worrying about it.
On behalf of the department, a little plaque for you.
Oh, thank you very much.
Thanks again.
Thank you.